Thank you, Ken. Actually, I'm the first student that can come back to Taiwan to study IBMS Institute of Biomedical Sciences in cell biology lab. I'm a clinician, so I work on lung cancer at that time. That is, I think it's 1988. So we start to, because at that time there's no cancer cell lines of Chinese or use the A549. So at that time we start to work on lung cancer because I think lung cancer is so unique. So we work on that, and we establish lung cancer cell lines and also the invasion metastasis model. Actually, that cell lines become very, very famous. I have a chance to look exactly how many labs using this cell line, and found in PubMed that more than 500 publications cite this cell line. So that cell line has become very, very important. So I took the my translational work in lung cancer, why lung cancer is so important. You looked at, because lung cancer is #1 cause of cancer mortality in Taiwan, both in men and women. But actually, Taiwan started a stop smoking program more than 10 years ago. You can see the smoking population decreased rapidly. Now in male, the smoking population is around 20-something, and female usually is about 3 to 5%. If lung cancer is due to smoking, you will see the decline of lung cancer incidence, but actually no. You can see that actually lung cancer is still going up, especially in adenocarcinoma, both in men and in women. So if you just stop smoking, you cannot prevent or you cannot cure lung cancer. It's not possible. So lung cancer in non-smoker is very important, especially in Eastern Asia. It's actually ranked number 7 worldwide. But in Eastern Asia, actually, especially men and women, lung cancer in non-smoker is very, very endemic in this area. If you look at Taiwan, lung cancer, especially in women, the #1 cause of cancer mortality is not breast cancer or cervical cancer. Actually, it's lung cancer. 93% never smoke. And even in men, now overall the lung cancer in never smoker is about 55%, smoker 45%. So lung cancer in never smoker is more than smoker. So we have a chance to look at the mutation profile, and we found that actually the driver mutation in Caucasian and Eastern Asian are different. We have much more EGFR mutant in our never-smoker lung cancer, and even in smoker, the EGFR mutation is higher than Caucasian. Caucasian is most dominant driver mutation is KRAS, and EGFR mutation is only 10 to 15%. So our problem is that never smoker become very predominant in lung cancer epidemiology, and especially adenocarcinoma. Female accounts for 40%, and more than 60% had EGFR mutation. Most of the lung cancer patients actually diagnosed very late in stage 3 and stage 4. So the strategy for screening early detection, we cannot follow the strategy or guideline set by for the Caucasian patient. So we need to initiate or develop the guideline for ours. But you look at the lung cancer natural history, how you can detect lung cancer is by chest X-ray, by CT scan, by MR imaging. But how many say actually when you detect the lung cancer? Usually you can detect lung cancer about 1 centimeter in diameter. That's about 10 to the 9 cancer cell already exists in the patient, because a lung cancer cell is only about 20 micron. You have to accumulate 10 to the 9 cells. Then you can detect by CT scan or by MR imaging. But when the cancer cell grows to 10 to the 12, all the patients die because of the tumor burden and metastasis. So the only way if you cannot detect the tumor, how can you do? You just can try to use biomarker to assess, to identify high-risk population. Maybe they can benefit from early detection to detect lung cancer. For advanced disease, you can practice precision medicine to make the best care of the patient. This is the partnership in cancer treatment. Before year 2000, the only way is by chemotherapy. After 2004, the era of target therapy started, and now we have immunotherapy. And before year 2000, it's very easy for the clinician. You can do only very little for the patient. You have no selection. No matter what kind of drug, chemotherapy drug you select, the outcome is the same. All the patients die in the advanced lung cancer patient. Most of the patients die within 1 year. The survival is only about 6 months to 9 months. No matter what kind of drug you select, all the same. But after year 2004, I think, the publication is done in year 2008, the milestone paper for the target therapy. In this clinical trial, it shows that if the patient had EGFR mutation, then you can select a specific targeting agent. The response rate can up to 70 or 80%. If the patient did not have, EGFR mutation, they did not respond to target therapy. So this is the start of the target therapy. At that time, clinicians start to know that you can have a marker. Then you can, based on the marker, you can select the best treatment for the patient. The response rate can up to 70 or say 80%. So now this is the guideline for treatment. Every lung cancer patient, you have to genetically profile the mutation, and based on that, you prescribe the drug. What kind of cell type, adenosquamous, you can also use this guideline to actually identify what kind of mutation they have, what kind of drug you should prescribe, then you can get the best response. Now we are entering the new era, so-called immunotherapy. And the immunotherapy, especially immune checkpoint inhibition, they initially they think that the program that's diagram 1 is very important. In more than 50%, you get a better response. However, in the recent study shows that maybe no need. Even patient does not have PD-L1 expression, they still had very good response to immunotherapy. And the mutation burden may be very useful for you to select the patient who can respond to the anti-PD-1 or anti-CTLA-4 immunotherapy. So we think that we need to implement the precision therapy for lung cancer patients in Taiwan. So with the help of the government, especially the Ministry of Health, and then we start the national reference lab. The national reference lab provide the gene testing for every patient diagnosed with lung cancer. They send a specimen to the reference lab. Within 5 working days, we give them the driver mutation, and our national health insurance will reimburse the drug. What are the impact? You can see the patient for this one. This is a stage 4 far advanced disease with metastasis of tumor everywhere. This patient usually survive only 3 months, but actually no. He immigrated to Australia actually, he came back to Taiwan. We checked, he has EGFR mutation. After 2 weeks, you can see all the tumor disappear. And the patient survived for more than 5 years, from 3 months to 5 years. This is a very significant impact. So this is the current practice. Every patient take biopsy or surgery, do genetic profile based on that, prescribe drug, and to see whether they have a druggable target, then we prescribe the drug based on the genetic or next generation sequencing profile. But if we implement this kind of precision therapies, this actually really very expensive. And there are some ethic issues. If only very rich people, they can afford this kind of precision therapy. But so this example, a far advanced patient can metastasis to liver, kidney, and you do precision therapy. After relapse, we do next generation sequencing again, and you can identify drug. The patient still can respond to the therapy. So they can have a very prolonged survival. You can also do the next generation sequencing using the Foundation Medicine platform. They can tell you the driver mutation, the possible resistant mutation may occur, or whether the patient can respond to immunotherapy. So next generation sequencing can help you to identify the suitable target. So this is the real impact. We implemented gene testing for the lung cancer therapy. At that time, the 5-year survival is only about 15 to 16%. But you can see the 5-year survival significantly improved. Now, the 5-year survival is nearly 39%, nearly 40%. That means that for 100 lung cancer patients, after 5 years, before only 16 survived. But now you can have nearly 40 of them survive for more than 5 years. So this is a very significant impact. Even for stage 4 disease, you can have 12% survival, 5-year survival. So really make a tremendous impact to improve the survival and also the quality. We can also use the liquid biopsy, use the cell-free DNA in the blood to monitor the cancer progression and outcome. And now you want to cure the lung cancer patient the best way, because smoking is not the only risk, and you cannot prevent that. The only way you can cure is by early diagnosis. You can diagnose lung cancer in days 1 centimeter in diameter. More than 95% of them you can cure by surgery. You just resect the tumor. This is a typical example. The X-ray cannot detect tumor. The tumor is here about 7 millimeter. We resect the tumor. The patient survives. Actually, you can cure the patient. So this is shown us work. You can see actually we established a genetic epidemiology study for lung cancer in Taiwan, and then we collaborate with NCI, and you can see in this paper we can identify the specific risk loci in non-smoker women in Taiwan, in Asia. So we think probably this risk SNPs can help us to identify the high-risk population. They can benefit from low-dose CD screening. We also identify a familial gene called YAP1. This is an oncogene. The YAP1 mutation may occur in the lung cancer family. This family example, father, mother, and 4 daughters all had lung cancer. All of them never smoker. The only son is a smoker, but he did not have lung cancer. So this is a mother and 4 daughters all had lung cancer, and they all have this YAP1 gene. The YAP1 genes can gain of function, can promote the cancer stem cell population. So we initiate the low-dose CD screening for non-smoker. We think their family history is very, very important. Now we have already screened for 10,000 subjects, and this is the interim summary report. You can see the lung cancer detection rate. The lung cancer screening trial called NLST down in the state is focused on the heavy smoker. The lung cancer detection rate is 1.03, but you can see the lung cancer detection rate in our low-dose CT screening focused on never smoker is even double the incidence of heavy smoker in the state. So this is very unique situation in Eastern Asia, especially in Taiwan. And most importantly, most of them, 95% stage 1. Actually, that means that 95% of them, by this low-dose CT screening, you can cure. You can cure the patient. So, because we have correct all the samples, so we now deduce a risk score based on the family history and the risk loci we have identified. We can develop a risk score model to predict the risk of subject who would have lung cancer. So by using this risk score, we hope we are able to identify high-risk population. And maybe they can benefit from the low-dose CT screening for the detection of lung cancer. And our surgeon is also very clever. Before, you had to do a very big thoracotomy here, but now, for early-stage lung cancer surgery, only one small pore, only one small, we can use the thoracoscopic associated assisted resection, and even patient does not need general anesthesia and local anesthesia without endotracheal tube, you can do that. Within 3 days, the patient can discharge from the hospital. So we also work on tumor microenvironment and also the lung cancer stem cell. We established the cancer stem cell culture system and dissect how they can crosstalk with the microenvironment. Most importantly, because before the cancer therapy always target cancer, they did not target cancer stem cell. Because we established the cancer stem cell culture system, so we are able to use this platform to screen for drugs that can specifically active against the cancer stem cell and also cancer-associated fibroblasts. We have already identified some of them are old drug, so you can repurposing the old drug for treating the lung cancer stem cells. So another area, we are trying to smart targeting the tumor microenvironment. Tumor microenvironment is very unique. It's relatively acidotic. pH is not 7.4, it's 6.8. And it's also relatively hypoxic. So you can use these two physical properties, relatively acidotic and hypoxic. So you can actually, we develop a narrow carrier. They are pH sensitive. If the pH drop to 6.8, the narrow carrier start to degrade and release drug. So can specifically target the tumor microenvironment. This is first generation. Now we have second generation. They both sensitive to pH and also lactate, because in tumor microenvironment, relatively lactate is enriched in that area. So we can have a second generation narrow carrier. They can also do tumor imaging. You can see the narrow particle who accumulated in the tumor part. So another small smart targeting system is that actually you can guide the nanoparticle by the magnetic field. Because we did a lot of MR imaging, we think that it's possible you can, at local tumor area, increase the magnetic field in that specific region. And then you can design a nanoparticle. They can just focus on, you can guide the nanoparticle, specifically focus on that specific area. Actually, we can do that. We can guide the nanoparticle to the tumor we are interested. So you can cure the tumor cell. In this particular story is by viral therapy. So before year 2000, we can have only chemotherapy. The survival is very poor. After year 2004, we start to have target therapy that's slightly improved in the survival. Now we have immunotherapy, and the immunotherapy can further improve the survival. We hope in the near future, by combination of immunotherapy, smart targeting, we are able to further improve the chemotherapy, immunotherapy, and combine with other target agent or chemotherapeutic agent, then we could improve the survival. So if anyone asks me, can lung cancer become a treatable disease? I always very optimistic say yes, it is in part. Thank you.